Good evening, all. And today is the 18th edition of our TMC Medlogs. And thanks for logging in. And today we have another distinguished luminary from our college. So I invite Professor Muralidharan sir to introduce Professor Thomas Paul to the audience.
Very good evening, everyone. Thanks, Dr. Venkatesh. Again, you have brought another wonderful practical topic and wonderful speaker to speak on the same. Somebody whom I have known for several years as a passionate researcher and academician. He is professor of endocrinology from Christian Medical College, and now he has been assigned an additional responsibility of starting a new venture. It's a mission in Ambilikai. It's a Christian hospital, Ambilikai, in Vadanjatram near Dindigul. So he's looking after that as a senior consultant in endocrinology as well as administrating that hospital. He has wide areas of interest, but he is focused in the last several years on metabolic bone disease and transplant endocrinology, for which he is well known not only in India but abroad because of his wide publications, more than 200 in national and international journals. He is the current president of Indian Society of Bone and Mineral Research, ISBMR, and also the vice chair of prestigious organization, what's called the International Society for Clinical Densitometry, the Asia Pacific region. With such wonderful credentials, it's appropriate that we have chosen him to talk to us today on a very practical topic, age-related bone loss, and he has chosen to be focusing on the area where most of you live and practice in, the South Indian perspective. Over to you, Dr. Thomas. I'm sure you'll throw light on such an important topic in the next 30 minutes or so. Over to you.
Thank you so much, sir. Thank you for the introduction. Thank you, Dr. Venkatesh, and all my teachers, my colleagues, and students who are listening. This is my brief journey over last 2 decades with the help of my teachers in Tanjavur, after that in CMC, who is Professor Dr. Seshadri, who was my mentor, who is a graduate of Coimbatore Medical College. So next 30 minutes, I like to briefly go through what it is age-related, most of it from South Indian perspective. And I limit mostly to post-menopausal women. I will not have time to touch so much on the men, so which I can do it later. Now, a sample case, this 67-year-old lady, she has got mechanical back pain and she has been postmenopausal for many years, type 2 diabetes and hypertensive. She is towards the overweight side and she has a knee osteoarthritis. She has got significant sensory motor neuropathy. And glycemic control is not that optimal. And renal function at this point, I not mentioned about urine protein. Of course, it was she has a nephropathy also. And if you look at her bone profile, the metabolic profile is normal. Vitamin D is, we say 18. Some people say less than 20 is vitamin D deficiency. And if you look at the DEXA scan, which is a gold standard for diagnosing osteoporosis, T-score is less than or equal to minus 2.5 here. She has got severe osteoporosis. If you look at her, she is kyphotic and she has got a fracture, which you can see on your right-hand side. She has got vertebral fracture. She has never received treatment for osteoporosis. We lost the time. And she is getting managed for only diabetes and hypertension. This is a patient which we have seen in our setting. Then I got a DEXA done in Vellore. Osteoporosis is often under-recognized and under-treated problem. Fragility fractures come with significant morbidity and mortality. I don't go into pathophysiology, which we can read in textbook. We know that vitamin D deficiency and poor calcium intake in most rural Indian setting. Of course, we can say in urban setting now. For the students, osteoporosis is not osteomalacia. That is the mineralization problem. Osteoporosis is, there is a condition where there is a bone density, bone thickness is lost. So, which predisposes to increased bone fragility. It is most commonly seen after menopause and elderly men. They can result in fracture, fragility fracture. That is, even sitting from a chair, just sitting on the floor can result in fracture. In men, alcohol and smoking can cause spine fracture, mostly asymptomatic in women, and distal forearm fracture and humerus fracture, distal forearm as well as hip fracture. Always, as a clinician, we have to rule out secondary causes. Now, we got DEXA in Vellore. I was part of this project in 2000. And so we didn't have any data on prevalence of osteoporosis in southern India. We were hearing in 2000, sir, will always say that like vitamin D deficiency everywhere. So we had a community outreach, both semi-urban and rural setting in and around Vellore. We wanted to do the studies of osteoporosis in postmenopausal women. So that time, we were focusing on little interior Vellore as well as in the Tirupattur. Now it is Tirupattur district. Previously it was Vellore. So in men, it was about 20%. I will not touch on after this. But in women, what we found was we had a small number in semi-urban area. 50% had osteoporosis when we did a DEXA scan. That is a T-score of less than or equal to minus 2.5. Later, we did it on a larger sample of 1,500 women, postmenopausal women in Tirupattur. We found that once again, it is around 45%. As the age advanced, the osteoporosis prevalence also. So it's a very huge magnitude. We'll be wondering, so what? We are talking about a number. We don't stop here. So later, what we did was we looked at whether it is translated into the fracture. When we did fracture assessment, especially vertebral fracture assessment, we found that 1/3 of them already had vertebral fractures. They are all ignored as back pain. So they thought it is age-related, degenerative, but they already had vertebral fractures. So it is a large number, 36. In Delhi also, they reported about 22%, that is urban. Here, we are talking mostly rural area. Now, so this is after 50 years. What about regularly menstruating women between 41 to 49 years? So here itself, before they stopped having periods, 15% had vertebral fractures. So this is the number we are talking about, grossly underestimated. Now, what about what is the risk factor? This is a study, we did it in 2010. We looked at significant people had low vitamin D, 100 people with a fracture who were treated with orthopedics department, and we had an age and BMI match control. After fixing the fracture, we followed them up. So we found that sedative, cataract, untreated cataract, and sedative use, hypovitaminosity, simple. They were all the significant factors which precipitated a fall and fracture. 1 year mortality in this population was 20% in 1 year. Though they were fixed and they were sent home, they died. This is the figure. We all know that it is reported in US, UK, everywhere. 20% of the women after 60 years who sustain hip fracture will die in 1 year. So this is very risky and we have to treat. I don't think any other disease will have this high mortality. Now, looking at the knowledge among these women, it is not there. In postmenopausal women, we looked at 300 women. We were just asking whether they know anything about osteoporosis with a structured questionnaire. No. What about premenopausal women? They also hardly know about the menopausal health pertaining to bone loss and prevention of fracture. What about doctors? This is about more than 200 doctors who are coming for some training program in diabetes. We looked at the knowledge gap with structured questionnaire. They were actually that it was less than 50% knew the significance of osteoporosis. Now, this is one of the very important study which we published about 3 or 4. We all know it's a menopause, estrogen deficiency, calcium. But the sleep, we looked at prospectively, about 700 recruited, finally about 180, 190 ended up with the study. If women have a less sleep, then they are at more risk of developing bone loss and osteoporosis. So the sleep less than 7 hours in a postmenopausal woman is a high risk. The next risk we studied was salt. If somebody is consuming more than 7 grams, we all know for hypertension, for nephrology, for cardiology, for endocrinology, we know the salt. But in bone loss also, we found that if somebody is consuming more than 7 grams, they are at higher risk of having osteoporosis. So you can find in the this multivariated analysis after adjusted also, the salt intake stands out. So we know that we evaluate by calcium, albumin, phosphorus, creatinine, alkaline phosphatase. Very important clinical parameter in our setting is height measurement on a very good stadiometer, serial height measurement, and always assess risk factors for fall. And many setting DEXA scan is not available. So we go by X-ray spine and risk factor available, risk factor assessment. Because many of them are vitamin D deficient, many of the Indian patients, we don't regularly recommend vitamin D measurement because it is not cost effective. What we measure, we advise them to measure is calcium, albumin, because albumin corrected calcium is important, and the renal parameters. Now, why the height is important. This is a case getting treated with us for almost 7 to 8 years. You can see that patient came, her height was 160. She lost 10 centimeter and she came, we just gave all the treatment, whatever is available. Then you can see she is stabilized at 148 centimeter. So the measurement of height is very important clinical parameter because we shouldn't ignore with a good stadiometer every time. Of course, the DEXA is a gold standard, but this is what we do in my setting. Now we don't have a DEXA in my secondary at this point of time where I am helping. So we do radiology of spine. We all know that the Jennen scaling can be used to see whether they have a fracture or not. And DEXA scan, yes, it's a gold standard. We use 3 sites, especially lumbar spine, proximal hip, and distal forearm. T-score in menopausal women, that is, patient bone density is compared with a young adult female. So T-score is how many standard deviation below the young adult reference. That is minus 2.5 standard deviation. So somebody has got a T-score of minus 3, patient has got osteoporosis. So anything less than or equal to minus 2.5 at lumbar spine or hip or femoral neck has got osteoporosis. Now, sometimes we won't be able to do in this side. So we have a forearm where somebody has got an overweight. Some diseases predominantly affect the cortical bone like hyperparathyroidism. And there, sometimes they will have degenerative changes in the hip and spine. There we can look at the forearm and we can use the same criteria of less than or equal to minus 2.5 T-score for diagnosing osteoporosis. Now, DEXA initially was with the BMD, bone mineral density measurement. Of course, all the other things have been added. We use all. We can look at the fractures. DEXA will tell you the fractures. DEXA will tell you the microarchitecture, which is called trabecular bone score. DEXA can tell us how much strain the bone has, that is bone strain index. DEXA will tell us how much muscle mass has, that is whether they have sarcopenia. DEXA will tell us hip geometry, that is the hip structural analysis. And in somebody on treatment, you can look for atypical fracture risk also. Now, in our center, we do 8,000 patients. Here also, we find geriatrics has got a less referral, though we charge them very less, like 1,000 rupees or 1,200 rupees. Still, the referral is less. Now, we all know DEXA is a comparison with young adult mean. Always say the mission has got Caucasian database as a reference. Whether we should have Indian reference database. ICMR provided one data and they said to use it. When we used it, we found that ICMR database, when we used, even in fracture subjects, we underestimated osteoporosis. Whereas later we got North Indian reference database, it was okay in making the diagnosis of osteoporosis. So always till we get a definite database, we are looking at a comparison of the Caucasian database as a reference to derive T-score. Now, this is a thing like, how the dental health, like, sometimes we see, with tooth loss. So I told, medical students come for some research topics. So I told them, go to a DEXA room and count the teeth, non-traumatic bone teeth loss. So we find that the people who have less teeth are more likely to have osteoporosis. We know that low BMI, advancing age, number of teeth, some people will be having low teeth at all. They are at a very high risk of having osteoporosis. So there are simple screening tools in a field we can do. This is, we have done in 2,300 people. They're all looking at a various risk factors, which we can easily do, like SCORE, HOSTA, ORI, ABONE. They're all there in the textbook. This we have tried to validate in our Indian setting. We found that SCORE, which includes so many risk factors, and we find that they have got a fairly good sensitivity in identifying people with osteoporosis. Another simple thing is OSTA, that is osteoporosis self-assessment tool in Asian. Very simple. We need only two parameters: weight in kilogram minus age in years, divided into multiplied by 0.2. If somebody has got less than or equal to -1, for example, somebody's weight is 40 kilos, age is 60. 40 minus 60 is -20. Into 0.2 is -4. That is, anything less than or equal to -1, we say high risk for osteoporosis. Fairly okay sensitivity, about 80%. Now we all know fracture risk assessment tool is available on the smartphone, and we can put an Indian flag, and there are various risk factors, and it gives two values. What is the 10-year risk of major osteoporotic fracture? What is the 10-year risk of hip fracture? Western countries use a cutoff of 20 and 3 for major osteoporotic and 3 for hip fracture. But we have looked at, even without a DEXA scan, just entering age, gender, height, weight, family history of fracture, previous fracture in the patient. Somebody has got diabetes, we can put it as rheumatoid arthritis plus glucocorticoid use, any secondary osteoporosis, smoking, alcohol, it will give you a score. And based on that, we can start treating the patient, initiating. It is for initiating treatment. It is not for monitoring. So this is a study I have done in this secondary care hospital. I have only X-ray spine. And how much is this FRAX? The FRAX is a free tool. Now, for last 1 year, we have FRAX Plus. FRAX Plus is addition. We have to pay per patient €1. That is, what is the addition of FRAX Plus is, if somebody has got a history of fall, that is taken into the account. If somebody is taking steroid, duration and quantity. Somebody has got a fracture. When is the last fracture? All this can be taken for correction. That is FRAX Plus. This is what we looked at. We here also in Ottanjatharam, we looked at 150 people, 34% already have prevalent radiographic vertebral fracture. Now, we know that the management is always important. This is a study. We wrote an editorial in Indian Journal of Endocrinology Metabolism when my teacher did a study, Dr. Seshadri, giving simple treatment like zoledronic acid with calcium and vitamin D. Fall prevention, very important. Nutrition with its protein, optimal physical activity, calcium 500 to 1000 milligram, all postmenopausal women, unless definite risk is there. All people should receive vitamin D, cholecalciferol, not active. Now, this is a study done in once again in our center. Just one of the medical student did, looking at about few number of subjects. We all know that except in state of Punjab, the calcium intake is way less than 500 milligram. So recommended calcium intake, we all know that it's about 1000 milligram per day. So many people require supplemental calcium either through diet or by tablet. So we recommend, like, 1 tablet of calcium carbonate a day, which has got the elemental calcium of 500 milligram. See, all the other things we have to be very careful. Calcium citrate we can use, but it is costly. But the advantage of calcium citrate over calcium carbonate, it is less GI irritant. So calcium carbonate, 1 tablet a day, that's what we tell them, which contains at least 500 milligram of elemental calcium. Now, vitamin D, this is a study. We looked at 95,000 people, and this is the biochemistry-based study. We found that across India, the samples have reached Vellore, and we found that more than 50% had vitamin D deficiency, which is defined as vitamin D of less than 20 nanogram. Now we say cutoff of 12. Now, we say all women and elderly men should receive vitamin D. We need not test. If at all we are testing, we should test only calcium, albumin, creatinine. All women should receive 1000 to 2000 units per day. If you ask the calcium tablet, that is not enough. Now, or 60,000 units once a month or once in 2 months. So don't use active vitamin D in treating osteoporosis unless patient has got a kidney disease. You can measure calcium, phosphate, albumin, creatinine, and alkaline phosphatase. This is a patient, they have given for a back pain, Arachidol injection every day. Patient has received 84 lakhs. So pathetic. This patient has got vitamin D intoxication. Patient came with PTH independent hypercalcemia. Unless specifically indicated, please don't use parenteral vitamin D. We use oral cholecalciferol. They either use it as daily or once in a month or once in 2 months. And we are living in India. This is a study from All India Institute. I always show this. We are about more than 100 brands of vitamin D. Some brands may not contain the prescribed quality. You can see some brands, they say 60,000, they contain only 5,000. So we have to be very careful which brand we use before you prescribe. So we say all women should receive calcium and vitamin D. Then we have medications. Somebody has got a fracture. Somebody has got osteoporosis on the DEXA scan. Somebody has got high FRAX score. Then we have to start treatment in addition to give calcium and vitamin D. We know that we have anti-resorptive. The common one we use anti-resorptives are bisphosphonates and denosumab. The common anabolic bone-forming agent we use in clinical practice is teriparatide, and nowadays we use romosozumab. Romosozumab is very expensive, about 26,000 per every month. So all this reduce the risk of fractures. So if you are using bisphosphonate, the number needed to treat to prevent one fracture, you treat for 3 years, number needed to treat is around 13 to 14. If you are using teriparatide, it is 11 to 12. So it's very small number, but you get a benefit and you increase the quality of life in a postmenopausal women who need good care. Now, these 2 studies are from our center. These bisphosphonates work very well and teriparatide work very well. Teriparatide is an anabolic agent. Daily we are using as an injection, 20 microgram for 2 years subcutaneously. And after that, we have to give an antiresorptive. Zoldronic acid is also 4 or 5 milligram you can use yearly. And they work very well. Now, what is the cost? This is the cost we are dealing with. Zoldronic acid injection once a year, 325 rupees. You get a fairly generic good calcium for 3 rupees, calcium carbonate, not calcium citrate. And cholecalciferol, 8 rupees. So, one patient per year is 1,450. It's very, very simple. If somebody has got osteoporosis, to prevent fracture, this is very, very cost effective. Now, when they have received treatment, if facilities are available, bone is a dynamic tissue. We can check in the blood bone resorption marker CTX and bone formation marker P1NP. We have standardized. We have got a reference range in South India. So we can look at it whether they are fitting in. If we are giving anti-resorptive like bisphosphonate, resorption marker CTX will come down. If we are using anabolic agent like teriparatide, bone formation marker will go up, P1NP. That's how it is. And it has got a good connection with the BMD. Now, very rarely you experience side effects with bisphosphonate. The benefit grossly outweigh the risk. This is one patient we had, like, had a atypical femoral fracture. She had received you can see that patient has got a right femur. It is an atypical fracture. On the left femur, it is beaking, and patient had to undergo surgery. But the benefit we give pertaining to a lady, all women in Indian women above 50 with calcium and cholecalciferol and osteoporosis treatment, either bisphosphonate or denosumab or teriparatide or romosozumab is huge because it brings down the morbidity, it brings down the mortality, it increases the quality of life. So this is the fracture. You can see for yourself. It's an atypical fracture, bisphosphonate induced. Very, very, very rare. Mostly we see this fracture when you are using bisphosphonate or denosumab while treating malignancy where they receive large doses. To summarize, osteoporosis is a significant problem. I told you 45 to 50%. With the fragility fracture, 35% of them already have got vertebral fractures. With the 20% mortality, we have simple, like, OSTA, fracs are all there. X-ray spine is there. Clinical measurement height is there. Agents are not costly. And we give calcium, vitamin D, and anti-osteoporotic agents in addition to fall prevention measures, optimal physical activity to reduce mortality and morbidity which resulting from bone fragility. Thank you so much. And it's not possible because we have a team. They all my students, my colleague Kripa and all that, they are part of the team. See, you look at these women, no, many of them are kyphotic and they never receive treatment. It is sad. We talk about stroke, we talk about hypertension, diabetes, we oddly. And I found that in PARC, textbook of social preventive medicine, we don't have a chapter on osteoporosis. So the awareness is less. So we have to, everybody has to treat. Family physician, orthopedician, nephrologist, endocrinologist, everybody has a right to treat osteoporosis, especially primary osteoporosis, postmenopausal osteoporosis. Thank you so much. Thank you, Dr. Venkatesh, once again for this invitation. Thank you, Dr. Muralidharan and rest of my teachers for this.
Thank you, sir. That was a packed session. It had a lot of information for us. And now the floor is open for questions and comments.
That was a wonderful talk, Dr. Thomas, as expected. I'm sure we'll have the appetite for more. Maybe 2, 3 other topics related to this may come up in future. I think we have quite a sizable audience today. 42 have logged in, so we can have questions from the audience. One thing I want to emphasize is that not only awareness among the general public, even among our fraternity, we don't talk the same language. This is one disease which is underdiagnosed and undertreated, at the same time, sometimes overtreated also. Like any osteoarthritis, any back pain,
Yeah,
even without getting DEXA, without checking for other markers of osteoporosis, people are given bisphosphonates in the form of combination tablets or short course of denosumab, teriparatide just for 2 months.
50 weeks.
All these are happening in practice. So that's
True.
first of all, I think we need to sensitize the orthopedic community who see osteoporosis much more than us, and majority of the time the vitamin D overdose is also from them. Even the simple calcium prescriptions you see across the country, we have costly calcium formulations containing active vitamin D,
Yes.
along with many unnecessary minerals which are added like zinc, boron, chromium. So many calcium tablets are available. I think the Indian Society of Bone and Mineral Research has to get in touch with the different companies and try to rationalize this also. We have many unwanted
Yes.
calcium
True.
prescriptions which are quite costly and which contain active vitamin D. And the patient, because they believe the orthopedic surgeon more, whenever they go from us to the orthopedic surgeon, they stop our simple shell cal and substitute it
With the
something
calcitriol.
something with the calcitriol containing, which as you very rightly pointed out, is not required except in CKD and hypoparathyroid. All these things
Yes.
have to be driven home at a primary practitioner level.
Dr. Thomas.
Sir. Yeah. Hello, Dr. Sir.
Yeah, very nice presentation. Thank you. And your original work and, over the years, this is really outstanding. So, two questions I had. One is, I was really surprised to see the data of 15% premenopausal women having osteoporosis, right?
Yes. 15% have got fragility fractures.
Fragility fracture, right? So, which is very surprising data. I was
41 to 41. Yes.
Yeah,
Yes.
I was not aware. So one question I had is that, like, have we looked into any genetic factors, particularly in this population, that would explain this kind of a thing? And again, the second comment I had is that, like, see the trajectory. I was recently in ICMR, talking about, how Indian physique is different, across the board. And I missed that talk about developmental origin of disease in our forum. But what Dr. Bail was indicating is that the data is coming that every part of the body, we are kind of lesser than, any of the population, Caucasian or other population here. So we are starting at a very different number, right? And we don't know the averages, for anything, right? For that matter, lung or kidney. The data is kind of very, very thing. So I think when you interpret the DEXA scan, like, as you rightly pointed out, I think there are challenges. What is the true kind of prevalence of osteoporosis in our population and the thing? So I think that's a comment I had. But I think those are two big thoughts that came to my mind. And third thing is about the relationship with the urine sodium and osteoporosis. So it's also interesting that, the hyponatremia association with osteoporosis,
True.
and there is a big store of this sodium in the, subcutaneous or other matrices as well, where sodium plays a very important role in the tissue integrity and things like that. So there are some papers I know that, they described more like a J shaped or a U shaped kind of an association where you have a lower sodium can have a link as well, and higher sodium also have a link as well. So those are three questions and comments that I had.
Yeah, I agree with you. But the thing is, we don't talk about osteoporosis alone. We are talking about fragility fractures.
Right.
See, that is the crude way of measuring women's health. So we are talking about 15%, and it is consistent. It's not only from our center. Even Dr. Delhi they are documenting about 22% otherwise healthy women. So it is, as you said, definitely genetics play a role. And of course, we don't have any data as of now. We do genetics in selected people, like that lady who I saying 148 and all that. But we couldn't get anything. So we have to work on it. I do agree. And so I agree. And there are some questions that are asked here, like, somebody was talking about I don't know. There are some questions have been asked, Dr. Venkatesh.
Yes, sir. Dr. Ranjit Pratap wants to know what's the difference between Z score and T score.
See, the T score is patient's bone density is compared with young adult female. We always use female, even for men, young adult. That is a norm, standard norm. That is T score. And Z score, as in other, we study in PARC, we compare age matched. That is the 60-year-old means it will be compared with the same age person. So that is the Z score.
The other question is, what is the duration of teriparatide use?
Yes.
And
Yes,
bone
sir.
markers, do they help
Yeah.
in treatment?
Yes, definitely. We've like a duration of actual duration of teriparatide, they say is 2 years, and they had a concern about osteosarcoma. But we use like somebody has got an ongoing bone loss, as in steroids and all that. We go up to 3 years. Of course, this is off-label. Mullidhan sir also will agree with me, and we use up to 3 years teriparatide because we see that anabolic window is still there in some patients. Regarding bone marker, it is very useful, especially when you give bisphosphonate, oral bisphosphonate, you check after 3 months, the bone resorption marker CTX will come down. If it is not coming down, then there is a problem with compliance or patient is not the medication is not patient is not taking correctly. That will give. Similarly with teriparatide also, when you give teriparatide within 1 month, bone formation marker P1NP goes up. It's very useful. And for the duration also, yes, to some extent for the bisphosphonate, yes. Because after 2-3 years, it will be markedly suppressed. Like, if you look at the CTX, we find it is 80, 90. And we keep on checking every 6 months. So we give a so-called drug relieving period because bisphosphonate has got a long duration stored in the bone. We give 1 or 2 years definitely off based on BTM and fractures. Yes, it is useful for the duration, especially with bisphosphonate.
Sir, are there guidelines? Dr. Sarayu wanted to know if there are any guidelines for treating older men, osteoporosis
Yes,
in older men.
almost similar. Almost similar. The treatment is almost similar because we see that's what I didn't have time because I thought I'll focus on men. I can do later after all the people we do the other aspects cohorts, other cohorts we have done. So we can do it, and the treatment is almost the same.
Does weight bearing exercise delay
Yes.
age-related osteoporosis?
Yeah, it's very important because definitely weight bearing exercise is good, especially for the hip. If you see somebody, their BMD, in that way, obesity to some extent gets a good BMD, especially in the femoral neck as well as total hip. Yes.
So my question is, for osteoporosis, especially using alendronate and zoledronic acid, our concerns are, I mean, your comments on the safety of these medications, especially when they are used in large scale, when you continue to use jaw necrosis and certain other problems. What are your thoughts on that, sir?
Sir, see, actually, I have data for 4,800 subjects in last 20 years. Sir also will have a large. I'm talking about 4,800. That is about oral or IV bisphosphonate. Institutes, PGI and all. We all use this, it's Madras Medical College. All the people use oral or IV bisphosphonate. We don't use that much denosumab. Denosumab nowadays is getting. We find hardly any in management of osteoporosis. But we have seen, see, we ask about atypical femoral fracture. So far in our center, we have 26 cases. But mostly they are treated for some other condition, like post bone marrow transplant or post breast cancer, like that. Even the jaw necrosis, I have seen only 3 cases. Of course, others will have a more experience, but they were all little unwarranted. That patient was getting zoledronic acid 4 milligram for 24 months. It is working out to be 96 milligram. This patient, without getting clearance, went and had a dental extraction, jaw necrosis. Otherwise, for osteoporosis perspective, it is usually very, very rare. Because, yes, sir.
Is it preferable to do a dental exam and then get rid of the old tooth before starting on bisphosphonates?
Yeah, generally dental hygiene is looked up. Yes.
Now the dentists are very aware. They are actually oversensitized.
That is on the other extreme, sir.
They immediately send the patient to us that please don't give zoledronic acid or withhold denosumab because I am going to do a procedure. So now our patients are, but these are usually the upper socioeconomic strata. They are much more aware. I don't know, in the community, we may not be having so much crosstalk between the dentists and the endocrinologists.
No.
In my practice, the dentist immediately will call me or will send the patient to me. There is one question from my classmate obstetrician, Dr. Veena Shankari. What advice you give for post-delivery patients' intake of calcium? Failure to take postnatally, does it lead to increase in incidence of osteoporosis?
Sir, you can also answer. See, there is something in the entity called pregnancy and lactational osteoporosis, but that is a very, very rare entity. But many women, while they are lactating and pregnancy, they lose calcium, but they gain, actually. They make it up. So anyway, for all women, we say at least 5,000 milligram is needed. So I will request your advice also. What do you think?
In extension to Dr. Swami's comment regarding genetic factors, I would lay more emphasis on environmental factors in our country because peak bone mass is already less.
Very true.
So, like you said, early origins of fetal origins of adult disease, osteoporosis is a disease probably which starts in childhood because the peak bone mass is achieved by the time the epiphyseal fusion occurs or slightly a year or two later. After 20, we hardly have any further accrual of bone mass, we only start losing. So, that may be one criterion why we have early onset osteoporosis.
I agree. Peak bone mass, it is, we have, from Delhi group, they said it's much lower than the Caucasian and especially Black, even Orientals. So that may be one other reason. Hello, Dr. Syed. Syed is my...
I just wanted to say thanks, Paul. Thank you so much. From day one, I just have to introduce Paul on my side. He's my classmate from Tanjore, 83 batch. And from day one, I've always seen Paul. He always looked like a professor, and he became a professor too. Congrats, man. It was a wonderful talk. So my thing is, I deal with, on the other end is physical medicine, rehab, and pain management. We see most of the people who already had a problem who come to us, like vertebral body fractures or now. So I wanted to ask you a question about how often do you see sacral insufficiency fractures in your population? Because that is one thing that is mostly missed among the clinicians even here. The people send, and it's pretty painful, and there's no apparent, there's no intervention to be done except weight bearing. I usually tell the people to walk and give them analgesics, and they do get better over a period of time, but it's usually overlooked. And number two is I would like to, point out that very important aspect that you said about PARC in social and preventive medicine, not including osteoporosis. We are great in, trying to catch the cat after it's run out. I think, hopefully with some, poking from your side, maybe they'll include this in the next chapters of social and preventive medicine, because the cost of treating people with osteoporotic fractures is staggering. Here in the US, it's nearly about $20 billion or so. And, and it's pretty painful, process. So thank you. Very good, talk. So do you see a lot of sacral insufficiency fractures?
It's all actually orthopedics referral. We don't see a lot. I think we may missing out. I don't know about Sir Muralidharan sir and Dr. Venkatesh and rest of them. I don't.
The reason I bring this up is because what happens is when they don't see it, all these older patients have stenosis. They have some radicular pain. So these people will keep on injecting them or they will be treating them. and just the patient doesn't get better. And unless you find out this what the pain is from, they're just going down the path of more and more, bone loss.
See, at this point, we always say, like, our policy from Indian Society of Bone Mineral Research, we don't have vitamin D fortification. So now we say that sunlight is practically impossible, 11 to 1. And we say all women, like, there is no point in keeping on checking vitamin D because many of them don't have malabsorption. All postmenopausal women should receive vitamin D till death. That is a current recommendation. Everybody should receive one packet of 60,000 once a month or once in 2 months till death. That is the policy. Calcium, preferably every day. And with this dietary intake, there is no increased risk of, I don't see any increased risk of coronary calcification or renal stone because we are talking about total 1,000 milligram of calcium. All women should receive.
And the other point I just wanted to make before I finish is I think a lot of people misunderstand also that, men also can get osteoporotic fractures. Yes. Although the ratio may be smaller, but they do get. And sometimes when they get at a younger age, it is very, I think, important to look if they have some other underlying condition, which can speak.
And
thank you.
Thing is, Dr. Sami is putting it across the GnRH agonist. See, the other entity is CA, prostate and breast cancer, no? There is a standard protocol for bone protection. But I have seen certain people don't do that. No, somebody is on aromatase inhibitor or somebody is on anti-testosterone therapy. They are at bone loss. And the best example is my father-in-law had a CA prostate. He was not on bone protective mechanism. I was on a student period. I didn't know. He had a spine fracture. So that is another group we have to really, and this endometriosis, yes, I agree.
In women, there is more awareness.
No wonder you went into osteoporosis because of your father-in-law.
Probably in women, there is more awareness. Gynecologists are more aware, whereas urologists who treat prostate CA, they probably don't refer the patients to endocrinologists. That may be another reason.
Yes, sir. There are some people who don't give.
And as far as CA breast is concerned, anyhow, the oncologists are using zoledronic acid or denosumab for a different purpose to prevent bone mets, and that takes care of osteoporosis also.
Yes, sir.
I think there's one more question they've asked about when do you start anti-osteoporotic treatment after fragility fracture and contraindications for calcium treatment that you have seen in your practice.
So the first one is previously there was a concern about starting bisphosphonate after fracture. Now that concern is gone because there are so many studies are there, like the before patient gets discharged, even after surgical intervention, we can give anti-resorptive, even anti-resorptive medication. So the answer is as early as possible. It doesn't hamper the healing. Number two is you were talking about
contraindications for calcium.
Calcium contraindication, sir, with somebody has got a very good oral dietary intake of calcium more than 1,000. Yes, it's okay. Otherwise, many of them do 300. See, in this part of Tamil Nadu, where I am sitting, central, and in Vellore, we find only 300 milligram of calcium. So adding 500 milligram, I don't think there is a reason for. Of course, we always check as far as possible calcium, albumin corrected calcium, but that is not the thing. But mostly adding 500 milligram of elemental calcium in most rural Indian setting or urban setting doesn't increase the risk of renal stone or coronary. Same thing apply for this tissue valve also. Why they should have increased calcification when we are talking about only we are reaching 800 milligram per day.
Yeah, many people confuse the dystrophic calcification versus metastatic calcification. My coronary calcium score is so high, so should I stop calcium? This is a common question. And in this part of the country, our nephrolithiasis rates are quite high. So again, the patients are justifiably asking whether I should continue calcium. We tell them we'll give less of supplemental calcium and more of dietary calcium and substitute citrate for carbonate because citrate has a anti-calculus property.
Yes.
They should not be restricted. Nephrolithiasis patients should never become, they should receive appropriate calcium in the diet. If they don't take adequate calcium, they'll form more stones.
Actually, there is a hypothesis that has been proven now called the calcium deficiency hypothesis, because there is a secondary hyperparathyroidism which promotes more hypercalciuria, and
Yes.
the calcium stone risk will actually increase. Many people still wrongly think that giving them calcium will further worsen the nephrolithiasis.
Sir, one more question, sir, regarding the use of combination agents, like you use the anabolic with the for example, bisphosphonate followed by denosumab, or denosumab followed by bisphosphonate. I mean, these combinations, are there any contraindications to use it
We
for a
don't
short
use
dose?
both anti-resorptive we do, but we are used in selective setting. Anabolic plus anti-resorptive dual therapy we are used. That patient which I talked about, the patient on teriparatide was losing so much bone in spite of giving anabolic agent. That time romosozumab was. So I added denosumab on teriparatide. But I don't know about taking two anti-resorptive agent together. I don't have knowledge. But there are some indications where you give anabolic agent, then if the bone loss is still ongoing, patient is fracturing, PMD is going down, then we can add anti-resorptive. That is
My
there. But
question is about
no.
sequential use, sir. Sequential use.
Sequentially we use.
Used.
Use.
We use.
So are there any specific I mean things which we should not do in kind of in the sequential
See,
usage?
yes, see, when you are using denosumab initially, and if you have exceeded 3 years, that is what the current protocol is, that is more than 6 doses. If you are going to stop denosumab and you are going to give zoldronic acid, the 1 dose of zoldronic acid may not be enough. You have to give 6 monthly at least 2 doses, because the bone that rebound fracture rate can be quite high. That is one. Number two, somebody on teriparatide, then you can transition, or romosozumab, you can easily transition to denosumab and zoldronic acid. And one more thing we find in our clinical setting with zoldronic acid, we find flu-like reaction. So now we got what is based on a New Zealand article, we give dexamethasone tablet on the day of administration, and the day, that is day 0, and day 1 and day 2, 2 to 4 milligram. That brings down that flu-like reaction significantly with zoldronic acid and bisphosphonate, other bisphosphonate.
But
Vellore is also. Go ahead, sir. Please go ahead.
why don't we continue denosumab for a longer period?
We can continue, sir. 10 years, no? Because the BMD keeps on going up, unlike zoldronic acid. There are some people want to stop. They then we transition. We have gone up to 9 years also. So you also will have an experience. 8 years I have given. We are continuing. Yes.
Zoledronic acid induced AKI, is that very common, sir? Because Vellore, Cuddalore, all these places are hotspots for this CKDU. And you find a whole lot of undiagnosed people where creatinine may not be, truly reflective of the burden. For these kind of patients, do you get across, see a lot of AKIs with bisphosphonates?
So to answer that question, see, generally we don't give anything. Even we are more conservative, more less than 35, we don't give. Those they say 30. I don't recollect nephrology sending that it is bisphosphonate. So I'm not sure. The answer I don't know, basically.
If they already have CKD and if they come to us, then we don't use.
We don't use.
I have not come across any case where it is causally related to bisphosphonate, AKI.
Thank you. Thank you, sir. Thank you for your.
Any other questions or comments from the audience?
Are we going to have another lecture from you, Thomas?
Sure.
Yeah.
Thank you.
Thank you.
So very nice listening to you, and thank you, Venkatesh, for putting this together. This is amazing.
Thank you, sir. Thank you. I think
And Dr. Murli, Professor Murli, as usual, his input is just phenomenal.
Thank you.
And Swami is gone out, I think. He's also there.
Yeah.
The gynecologists have mentioned even Marina insertion is on the higher side now, where do we advise to take calcium. Another intrauterine hormonal preparation for menorrhagia. there again they go into almost amenorrhea, induced amenorrhea.
So basically, you're saying therapeutic hypogonadism.
Yeah,
That's
yeah.
what you're saying.
But Marina, I don't think is a therapeutic hypogonadism.
Yeah,
It's
then
more
why
the
you want to be worried, sir?
no, they have somebody has
Dr.
asked.
Veena.
I don't.
Dr. Veena has asked the question. Yeah,
Oh, I'm not sure, sir. So
I
what
think
do
it has progesterone predominantly because these are estrogen sufficient, progesterone deficient patients in whom they insert Marina
Yes,
for
yes, sir, Marina.
abnormal uterine bleeding.
Yes,
So
sir.
even though they become amenorrheic, they are quite hormone sufficient. So they should not, they are actually hyperestrogenic. So they should not have osteoporosis because of this. Many of
So
them are obese.
one final comment on HRT, sir.
HRT, we limit up to some 50. See, like after 50, we don't use in Indian setting. And unless very few indications like significant vasomotor not able to control with the agents like venlafaxine, we give for a short term. Otherwise, we limit ourselves to 48, 49 maximum. That's what we do in our center. I don't know about others. We don't
HRT
use
for prevention and management of osteoporosis
osteoporosis, no.
is now gone out.
Oh, yeah.
It's only for menopausal symptoms.
Menopausal symptom.
But again, the thing is gaining ground that the WHI had drawn incorrect conclusions based on higher age group and the critical age hypothesis that is more important. So earlier age of menopause, definitely we are using it in premature menopause
100%.
and POI. So till the age of 45, 47 also we are in select
We are
cases we use
comfortable.
HRT.
Yes. But that was a wrong conclusion because they had a higher age group. So that went into negatively. Yes, sir.
Yeah.
Dr. Thomas,
Yes.
regarding calcium advice for patients who had undergone a heart valve surgery with the tissue heart valves.
Yeah.
One of the complications is a calcification the valve replaced valves.
I don't think
Thing
it is
is,
related to that.
that's what we spoke, up to, see, the requirement for an adult is up to easily up to 1000 milligram. So if our intake through the dairy or other sources are 1000, there is no need for replacing. But somebody has got, like a lady, postmenopausal woman, has got some 300 milligram, then adding one tablet, theoretically, at least, I don't think it will increase the risk of calcification because we are talking still in the physiological range. What is the National Institute of Nutrition describes.
Thank you, sir. Wonderful lecture, sir.
Thank you, sir.
Thank you, Paul. My one question, thing this, Paul, is very important. Another thing is for all of us is this osteoporosis is going to just be more and more prevalent because people are going to live longer and longer. And the issues that come with the disability of that is going to be profound. So I think that's an excellent thing that you brought on, and thank you.
Thank you. Thank you, sir.
I think if that is all, then we can probably call it a day. I thank Professor Thomas Paul, sir, for this wonderful lecture and for sparing his time and expertise for us. And it's been a very nice discussion. And for the first time, we hit 43 at some point of time in the lecture, the total number of attendance. It shows that people are showing more interest. Hopefully, we'll bring in more topics of which will be of interest to wider audience. And I thank you all for today's session and for a very beautiful discussion. Thank you. Thank you all.
One question just before you finish, Venkatesh. I wanted to send this on the conference as well, but somehow it missed my mind. I think the issue was how do we get the youngsters involved in this? And I think that we're still not able to attract them from the medical school side. So I was thinking that some initiative you have to make. Right now the attention span for people is 30 seconds, and now they're coming up with all these TikTok videos. In that, whether we can start doing something like that is something that we have to it's something I'm just saying. Tell me if I'm wrong.
True, sir. Actually, myself and Dr. Jaya Venkatesh, we are trying to create reels out of the presentations, for which a few seconds and one pointed question in a few seconds. But I'm not very tech savvy, so Jaya Venkatesh is actually trying to look at it. So he said that we will do on 1 or 2 videos in the coming days. and then see whether we can get it across. And regarding the poor attendance from students, we have been sharing it with all the faculty members. So we are trying to rope in a lot of faculty from Tanjavur. They also keep sharing a lot of groups. They have been encouraging the student community to come on board. But generally, the interest seems to be very less. Probably we need to bring in more topics which are of interest to them. So I've approached a few of them to tell them what exactly they want out of this program, what kind of topics they would prefer. So we are working on it, sir. Hopefully in the future, we'll be able to get more on board.
Awesome. And then we maybe have to probably put an incentive and say people who come will have a 5 question, answer, and whoever wins will get a prize.
Good suggestion. We'll do that.
Anyway, thank you so much, Venkatesh, for all your efforts.
Thank you, sir. Thank you all. Good night.
Thank you.
Good night.
Good night.